Hi, everyone. Welcome to LDI's seminar today. We're thrilled to be doing a seminar today on building health and building wealth. We are being joined today by Amy Castro, who is an assistant professor and the founding director of the Center for Guaranteed Income Research at the School of Social Policy and Practice here at the University of Pennsylvania. She's also serves as a co-principal investigator of the Stockton Economic Empowerment Demonstration. Lucy Marcel is assistant professor of pediatrics and associate director of the economic mobility for the Center for the Urban Child and Health Family in Boston University. And she's also co-founder and executive director of Street Cred, which is a nonprofit providing financial services to low-income families and doctors' offices. Ioana Marinescu is an associate professor in the School of Social Policy and Practice at Penn also, and she's a faculty fellow, research fellow at the National Bureau of Economic Research. And today's panel will be moderated by George Dalembert. George is an assistant professor of pediatrics here at Penn and is the founding director of the Children's Hospital of Philadelphia's Medical Financial Partnership. George, I'll turn it over to you and looking forward to the conversation.
Good morning or good afternoon, everybody. I'd like to echo the welcome from Rachel. I am looking forward to a robust discussion today as we hear from our panel of experts, as well as those of you in the audience. My hope is that today's session will be only the beginning of an ongoing conversation in your various circles as to how your work and broader day-to-day experience really is affected by the topic of today's panel. To facilitate an interactive conversation, I want to define a few terms so that we have a shared mental model in our hour together. So the title of today's talk is Building Wealth and Building Health. So one of the things that unifies this audience is an interest in health, whether as a practitioner or researcher or the myriad other hats that audience members wear. And I dare say that interest more specifically is in optimizing health for patient populations. But what do we mean by wealth? So wealth is commonly measured by net worth, which is most simply defined as your assets, so like all of your resources, that's your cash, your stocks and bonds, your land, minus your liabilities. And so like any resources that ultimately belong to someone else. And another important definition that we'll have in this discussion is income, which is defined as kind of the money you receive in exchange for working or producing a service or a product or investing. Importantly, compared to income, wealth is built intergenerationally. And so accumulating assets that are passed down and grow over time by bequeathing land or property, interfamily transfers, that type of thing. And of course, if you have a steady stream of income, that can help to build your wealth. So with these basic definitions in mind, and before I bring in the expertise of our amazing panel, I wanted to provide some context. In 2020, there were about 37 million people in poverty, so that's about 11% of the US population. And that was approximately 3 million more than in 2019, likely given the effects of the pandemic. Among non-Hispanic white individuals, about 8.2% were in poverty, and Hispanic individuals had a poverty rate of about 17%. Black individuals had the highest demographic poverty rate of about 19.5%. And the child poverty rate also increased from 2019 to 2020. And to be concrete about what this looks like, before you potentially start to rationalize like 11% poverty rate isn't that bad, the poverty threshold for a family of four with two kids is an income of about $26,000. So now it surely comes as a surprise to probably no one that wealth is not equally distributed in the United States, but how unequally distributed can be a little bit jarring. And so, for example, data from 2019 showed that the richest 3 people in the United States had more wealth than the poorest 50% of Americans. And so even when we don't consider the Musks and the Gates and the Bezoses of the world, there is plenty of inequality when you compare wealth among Americans, especially when you consider the racial wealth gap between Black and white Americans. So Black Americans are estimated to have 10 times less wealth than white Americans. And so the median net worth of a white family was about $190,000 compared to about $24,000 for families in 2019. And past research has shown that 25% of Black families have zero or negative net worth. And to be clear, it's not just for a lack of working hard or any personal attributes. It's often systematic intergenerational barriers mediated by the effects of racism. Social determinants of health have become a really hot topic recently. Poverty is an incredibly important determinant. Indeed, it's been called the greatest threat to health by some. And so generally speaking, poor people are sick more often than wealthier people, die younger due to poor economic, social, and political and physical conditions. And the unequal distribution of poverty is associated with an unequal distribution of wealth, and that wealth gap is also based in historical and contemporary processes, access to public resources, quality of education, housing market, all types of factors. And these influences really come together to yield the health inequities that we see amongst our patients, in our communities, and perhaps in our own lives. So addressing wealth as a mediator of health has been a research and policy topic for a long time and has had some recent exciting developments. For example, policies like the expanded earned income tax credit or child tax credit, which have recently been enacted, experiments with guaranteed income and cash transfers, and all of these interventions really open the door for a brighter future. And so today, with our kind of amazing group of panelists, we're going to do a little bit more exploration of this complicated, really nuanced topic. And so with that, I do want to go ahead and start to bring in our panelists. I'm going to direct our first question to Amy, and we'll start with Joanna and get some insights. We've known for a long time that wealthier people are healthier people, but what do we really know about increasing wealth as a way to improve health? For example, do we have examples of when or how it has or hasn't worked?
Yes, this is indeed a critical question given all the patterns of inequality that George has just been talking about. And that's where we need research to look into this, and it can be difficult to understand how wealth influences health because there are many potential pathways. And so, for example, it may look like wealthier people are healthier, but maybe it's not because of wealth, or not only, it might be because they are more educated, etc. So there are many factors, not all of which we can always properly account for, that could explain this correlation essentially between wealth and health. And so in order to try to get a clearer handle on this, it's useful to look into experiments that change people's wealth or people's income, which is something that Amy, I'm sure, will talk about with her experiment. But there's also been a whole line of prior literature looking at how changes in people's income that are as good as random, so that either are literally an experiment or approximated an experiment, so that we get away from all these potential other factors that might be floating around. How do these affect health? And so there's a study in the US looking at Native Americans and the fact that they receive unconditional income from their casinos that run on their reservations. And we can compare the outcomes of the Native Americans with non-Native Americans living in the same area who therefore don't receive this income, and also before and after the income started coming in. So that study shows that there were important improvements in mental health in particular, and issues of substance abuse. And this was concentrated among youth in the relatively more disadvantaged groups among Native Americans. So positive effect there on health, and especially mental health and substance abuse. Then if you look more broadly, we can also learn from studies of lottery winners, which is, again, a kind of cash that is completely unconditional and is randomly assigned by definition of a lottery. And what's interesting there, and I think it's really a way to understand US policy a little bit in perspective, is people have looked at this in Sweden and looked at health impacts of winning the lottery. And so what they were able to see there is that in terms of, and this was also concentrated on both mental and physical health, there weren't any effects except for your feeling of financial security. So in Sweden, for the most part, getting more money was mostly associated with feeling financially secure, but it didn't have an impact on broader measures of well-being or mental health issues, etc. But I want to bracket this by saying that this is Sweden. And that's very important to remember. Sweden has a much lower income inequality than the US, and it has a much more solid social safety net, including very strong health programs. And so it turns out that in Sweden, giving people more money didn't have a clear impact on health, again, with the limitation of just financial satisfaction, but no big impacts on health otherwise. But that's likely because they already have a system of social protection and health insurance that leads to fewer inequalities and allows people to already live a healthy life more or less at all levels of income in the population. And so I think that we can learn a lot from that, therefore it's possible to do better. And if we did more, there is a chance that we'd be able to break that link between income and health, since in that case, again, giving people more income didn't seem to have a big effect in terms of improving health. So I think in that sense, it's a very hopeful message for us going forward and thinking about what policies we could implement that would change things for the better in the US.
Thank you so much. One follow-up question, thinking about kind of like those policy options, what are some of the challenges in terms of crystallizing the evidence base for these connections? Like, do we really just have a lack of tools to be able to understand the causal relationships or other factors that impede our ability to advance evidence-based recommendations?
I think really the issue is more along the lines of political feasibility or just challenges. Not to say that there are just significant challenges in this for a number of reasons. One of them is that people are worried that giving people money will either prevent them from working or increase like drug and alcohol consumption. As I just explained, that study showed that it was precisely the opposite, that having more income would decrease substance abuse issues. And when it comes to work, the research as a body of evidence shows a very limited impact on work, sometimes no effect, sometimes a small reduction in hours. So this is definitely not a major concern there. So, but I think a lot of people don't know that. So it's important for us, I think, for everybody to realize that that's the case. And then next up, it's thinking about financing. So, how are we going to, increase budgets in order to pass this policy? And for a long time, it's been thought that, we can't afford it. But with the pandemic, all of a sudden, we significantly increased cash transfers in a number of forms, including the child tax credit, which makes a huge difference to child poverty, is unconditional cash and is, hopefully going to be continued. And so, it's all partly about seizing the moment, and striking the iron when it's hot.
Awesome. And thank you for those insights. As we talk about seizing the moment and generating good evidence, Amy, I want to transition to you. In your Stockton randomized trial, you gave 125 people $500 for 24 months, no strings attached. And you found that guaranteed income had positive mental health impacts on program participants. What are the implications of this pilot for wealth building policy more broadly and the potential effects on health?
That's a great question, and one we're sort of grappling with figuring out truthfully how to answer at scale in terms of policy. So first, I'll just kind of like run through a little bit of kind of what those results were. So we've released our first year findings. Basically, we have 1 year of pre-pandemic data, and we have a second year of data during the pandemic that will be released in spring of 2022. And what we saw specifically after that first year was that as you calmed income volatility, so money going up and down each week or each month in a household, we really saw, decreases in, of course, income volatility, which generated changes in anxiety and depression specifically, also the amount of reported pain. So importantly, at the start of the treatment, which the treatment in this case was literally just cash on a prepaid debit card, nearly every member of the treatment and control group met the clinical criteria for either anxiety or depression. I mean, these are standardized measures that are used, many doctors' offices. And if you're on the call, you probably have used these scales yourself. And so at the beginning of this study, basically people met the clinical criteria for anxiety or depression. Fast forward 1 year, and we saw the control group basically stay the same. And the treatment group moved from likely to have a mental health condition to likely to be well. And literally we did absolutely nothing else except give unconditional cash, which is incredibly exciting as a research finding. But when we're thinking about it more broadly in the context of wealth accumulation, I think there's some real limits to it. And it, to me, as a scientist and somebody who's looking at this through a policy lens, really begs the question, like, yes, unconditional cash can do tremendous things and reduce anxiety, reduce depression, which then shows up as a more positive social determinant of health in the long run, we hope, right, with some of our larger experiments. But cash can only go so far. I can give everyone in America $1,000 a month, every month, for the next 5 years. But if that's not paired with policies that give people safe access to banking to protect that wealth, and have equitable access to the market, we're going to hit a ceiling. So it's really, it's sort of thinking about cash plus what, to me. And I really love the way that you framed this at the beginning of differentiating between wealth and income, because that's really where those disparities lie. And the other thing that's really been standing out, not just in the Stockton research, but some of the other pilots that we're running in other cities, is the ways that families move money around networks. And I think we can't talk about health and wealth without talking about the way that most people live, which is not the way we count things in our data sets of head of household. This is how many people live there. No, in reality, that strain that's felt in the community that shows up as poor social determinants of health, those strains are pushed onto whoever is the most resourced in a network. So, one of the things we saw in Stockton was that people kind of quietly use that $500 to spread that cash around financially fragile networks, in a way that stabilized finances beyond that individual household, right? But in that same way that cash was kind of pooled and spread around to build support, that's the same way that risk works, right? So if you're a household that's stuck in a community where you don't have safe access to banking, and in fact, you're targeted for risky products, or your wealth is being depleted over the generations, risk is also filtered in that direction as well. So the way that we're thinking about a lot of these pilots around unconditional cash is saying, what are the opportunities with guaranteed income or unconditional cash? And then what are the limits? And then when we talk about those limits, I'm of course thinking about it through the lens of wealth building and, financial stability and economic mobility, saying what are the other policies that we need to think about to really close these gaps around families that are at risk. But as far as the health components go, seeing those shifts in anxiety and depression were pretty extraordinary. I mean, we weren't surprised, like we chose that hypothesis for a reason. We thought we'd see change. We just were surprised at how quickly it took place.
That's an excellent summary and some really great points there. I think you did a great job of kind of like looking ahead as to what some of the challenges are. I'm wondering, can you use any of the research findings in your other experience to talk about what the implementation of your study and others have taught us about the role of more historical social welfare programs and potentially some of the gaps and opportunities with those?
Yeah. Oh my goodness. There's so many. I mean, the other thing I neglected to say, which, I should throw out there first, is that, financial scarcity creates time scarcity, right? And so that time scarcity, it decreases people's bandwidth. It limits their capacities to set goals, to sort of come up with alternative pathways of finding new ways to, forge a future or build wealth, things of that nature. And so first I'll say, when we think about an infusion of cash really calming income volatility, calming anxiety and depression, and increasing cognitive bandwidth, we really don't know yet how far that will take us. And when that meets up with historic policy, when I think about kind of this momentum that's on cash, right? So when we started Stockton, it's 3 years ago, I guess, we were one of just a handful of experiments in the US, talking about this. And Dr. Marinescu's been doing work in this area for years, but actually running experiments, this is new. And fast forward to now, and there's over 100 pilots taking place in the US with a child tax credit. Of course, we had the CARES Act stimulus payments and all these different forms of cash. But if I look at any social problem right now, I can trace it back to gaps in the New Deal era and in other moments in policy history where people who were locked out of those benefits, those inequalities accumulate over time, right? So when I think about the momentum on cash right now, figuring out that end user and saying, who's potentially being left out of the child tax credit? Who's potentially being left out of stimulus payments? Who's potentially being left out of these pilots are key questions, because it's not just are they eligible, but do they engage with policy take up? So for us, like if we don't close that gap, for those of us that are doing implementation in this space, we're taking that inequality that we've inherited since the 1930s and we're writing a new form of it into this new policy era that we're in. So it's sort of an open question. It's hard to answer kind of where are we headed, but those of us that are doing applied work in this space are fairly fixated on this question because we know we have an opportunity to close those gaps. But if you're mixed documentation status household, why should you trust me, right? Or why should you trust the federal government? You probably shouldn't. But these are some of the policy questions that we need to answer, moving forward in terms of human-centric design.
Thank you so much. And part of what you were mentioning was just kind of how our systems have proposed some challenges. And we talk about a lot of the government systems, but health systems, I think, also have a role to play in this. And so, Lucy, I'm actually going to turn to you here. Increasingly, healthcare systems are thinking about that role in addressing poverty and the financial challenges of their patients. And you are a national leader in a lot of this work. And so what is their role, in your opinion, and how is this playing out across the country?
Thank you, George, and thanks so much for having me today. I completely agree with what you just said. There is a role for the healthcare system in addressing financial challenges that our patients are facing. And I would even argue that it's a health intervention. So first, I think it is important to acknowledge, as we've heard from the other panelists, that some of the evidence on this is still either equivocal or we are in need of greater evidence to say for sure this is causative. But there certainly is a strong correlation with mental health and both income and assets. And there are relatively good data that tax credits like the earned income tax credit, the child tax credit, are also associated with positive changes in health outcomes, things like increased birth weights for babies. And so as a pediatrician and primary care doctor, I think of that as health intervention then. And actually, to the point that Amy just made, I think our role comes in with her question of who's being left out. So, there are many people, unfortunately, who are being left out of these social policies. They are often the people who most need these policies and stand to benefit the most, both financially as well as potentially in terms of their health. They're hard to reach. They don't trust systems because systems have proven that they are not designed for them. But as physicians, we do have their trust, and we actually see them frequently, especially in primary care, both for children and adults. And so I think that is where we come in, that we can be this broker to bring these resources directly to our patients that stand to improve their health outcomes, as well as to help them feel more connected to the health system and make better use of healthcare services as a result. My team is leading some qualitative research right now in which that is very clear, that parents are saying to us, before I used to feel like my interactions with the doctor were more transactional, but because you're helping me open these savings accounts, we now feel like it's a more holistic approach. You actually care about my whole family, that we're really in partnership together. And in human-centered design work that our hospital, Boston Medical Center, has undertaken, families have clearly identified financial well-being as, in their view, a key component of their health and something they would love the healthcare system to get involved with and help them be more well. Just to touch a little bit more on this idea of who's being left out. So most of our work does focus on tax credit uptake, child tax credit, earned income tax credit. We run a tax site at Boston Medical Center. We have for about 6 years to increase uptake. But for those of you who are less familiar with taxes, about 20% of families every year who could be claiming the earned income tax credit, which is up until the child tax credit, the largest refundable source of cash available to families. We found that in our population, 20 to 30% of them do not claim it every year. And that is reflective of national trends. And that there is both problem of not knowing how to claim it, but also not even knowing that it exists. This summer in our clinic, we've done a lot of outreach work with families around the child tax credit. And despite all the attention in the media, 50% of the families we've been talking to are not aware of it. They don't know if they're eligible for it. And yet they are the very people that it's designed for. So I think that just really highlights the need for this kind of more grassroots approach that healthcare can be a part of, meeting people where they're at and using that trusted relationship to make sure they're empowered. I'll pause there. There's a lot more I could say on this.
Thank you, Lucy. I am actually going to ask you a follow-up question, and I just want to remind our audience that this is a conversation. So please throw your questions into the chat. We want to integrate your thoughts and your questions into this as well. Lucy, one follow-up question. So you mentioned some of the great work that you're doing. What are the barriers to scaling these types of programs? Why aren't more places actually engaging in this type of work to fill that gap that both you and Amy mentioned?
It's a great question. Unfortunately, there are several. So one I would say is, of course, funding, which everyone always thinks about, but who is going to pay for this work to be done? And I've been lucky so far in that we mostly have philanthropic funding paying for it, but that is not a sustainable long-term solution. So part of our goal is to build enough evidence on the impact of this type of work to then build a case for either hospital systems or health insurance providers to reimburse, especially as we think about ACO models and the fact that this could be something that could change whether people come to primary care appointments, whether they have cash in their pockets to fill medications for chronic disease and avoid hospitalizations. So I think that question of who's going to pay for it is a big one. And we run a medical tax collaborative that has about 24 members nationally and across 10 states and DC. So there's clearly a lot of interest in this work. But I will say the most common reason that groups who are either in the medical tax collaborative or have talked to us about joining it do not move forward with implementing is that they don't have funding. They don't have anyone who has time to actually do it. And it's not necessarily so expensive. Most of the tax preparation work is done by volunteers, but you do need a couple of people who have some time to organize it all. So that's one issue. Space, of course, in healthcare systems is another issue, and during the pandemic has become much more challenging finding places to actually provide these services for families. We moved to a virtual model, and we're now moving back to a hybrid model. But even with that, there are concerns about social distancing, and the space we typically use is being used for COVID vaccines now. So, how do we negotiate all those different space demands? And then I think there's also still a little bit of a question in some people's minds about, like, is this the healthcare system's role? Are there other things that we should be doing instead with our time? I think my work as a provider, again, has made me feel pretty certain it is our role. That, when I talk to moms with new babies about their postpartum depression and offer them therapy, and the response I get is, no, I just want to be able to pay my rent and feed my children, then I won't be depressed. To me, it says cash is a health issue. But again, as we heard, cash alone is not going to be enough. We have to redesign our whole system to allow people to save their wealth and to not be penalized for making progress in their financial security, which gets to the cliff effect issue, which is a much greater topic we may touch on later. But so the healthcare system we can talk to our legislators as well about what we're seeing on the ground and use that to also make sustainable change.
Thank you so much for those additional thoughts, Lucy. I want to kind of continue that thread of kind of how do we make systems change. And so maybe opening this question up to the entire panel, and I start with you and invite you just kind of with like the broader context that you bring in terms of how can this be translated into policy at a national level when our legislative system is so divided, for example, with like the current budgetary issues. I think that follows up on a thread that you mentioned as to one of the barriers in doing this work.
Absolutely. So, I think it's all about seizing the moment and understanding good policy levers. So that's why I think Lucy's intervention is so interesting, because it doesn't require any legislative change. We already have the EITC. So it's a matter of, being able to make sure that everybody who is eligible has the information they need and the help they need to apply. There are other, programs that are underutilized, such as, for example, the child care subsidies for low-income families that most people who are eligible don't use. So I think part of the it's both about kind of building a bridge to something really ambitious and asking what can we do right now that would ameliorate the situation. And I think right now, anything we can do to push for the extension of the child tax credit is something that would have a huge impact on child poverty and therefore on health, as well as the issue, like as Lucy was explaining, of expanding impact. And then it's about how do you do it, in a way that there is somebody who will guarantee, like Lucy was saying, that this money, this effort is going to be used to do this. The good news is that it's not necessarily very expensive to help somebody file for the EITC relative to the benefit that they can get. So, in that sense, it can be an opportunity. And I could even see local authorities, the city or the state, potentially, having a program around that as one way to enhance health outcomes, among other things, for low-income populations. So I think we have to be a little creative in thinking what is an intervention that is easy to sell and is not particularly costly in this case, again, because the program is already there. So especially if it's something that you have to do in Washington, it's just so hard to pass anything that kind of ups the ante. That's not to say we can do it. And as we see, we have the child tax credit, which is wonderful. But, it's this, and be ambitious and do the small fixes that are going to improve, people's chances today.
Yeah, I definitely welcome thoughts from the rest of the panelists on that. Great question from the audience. And as we kind of think about like how do we turn this into practice? Amy, go ahead.
Yeah, sorry. I was having a little bit of trouble with my mute button there. Sorry. Okay. So for as terrible as things are, like y'all, like, come on. We're the most like divisive moments in US history politically. And we had presidents on both the right and the left in the past 2 years pass policy on unconditional cash. That is extraordinary. So like on the one hand, like, yes, we've got problems, right? But on the other, we are at this moment where we have this policy window that is open. And I mean, to me, like it's exciting. Like, yes, it's frustrating, but I mean, I've been doing work on poverty, either as a social worker or as a researcher for, at this point, almost 20 years. And I've never seen the amount of public discourse and dialogue kind of fracturing and opening up the way that it has in the past 2 years. So I will say that sort of I'm far more excited than not about where we're at with this, simply because, on the one hand, like, yes, we have fracturing. Yes, we have gridlock, right? But on the other, we have some extraordinary leadership taking place. And, part of the reason why cash is something that's, palatable is because it's quick and it's flexible, right? And so like poverty creates constant need, right? And those needs fluctuate by the day, by the hour, right? Cash is flexible, which is why it's such a quick sort of fix to stabilize those, to stabilize household finances, which is really exciting. So like, yes, like we're kind of stuck, but we're also moving forward. The other thing I'd throw out is that, one of the things that we're seeing in the policy space is, rather than things coming from the top down, even though, of course, I just framed my comments that way, we're really seeing this shift towards bottom-up federalism, where mayors, county legislators, people who are in city council are saying, I don't have the time to wait for the Biden administration to get their act together. Like, I've got people in my city right now who are experiencing extreme poverty, who are at risk of eviction, and who are experiencing new health problems because of the pandemic or from, historically being locked out. And so what we're seeing happen right now is a lot of experimentation on the local level, I think, is informing those higher levels of government. So, for those out there who are looking for a research topic, I would really encourage you to think locally and see some of the ways that mayors and counties and legislators are really experimenting with some bold ideas. And that's really pushing and prompting public conversation and even experimentation on a federal level. And so, maybe I'm more optimistic than I should be. But at the same time, I just can't help but see that a policy window is here, and I don't think that it will stay forever.
Can I add 2 quick comments, George?
Please do.
Yeah. So one point I think that kind of builds off of Amy's of like there's possibility for local action is that I think we're also seeing a lot of healthcare systems taking matters into their own hands. And an example would be that, a lot of healthcare systems are now looking at how do they build better jobs for the local community that pay fairer wages, that allow for paths out of poverty. And that is because of this national interest in health equity and racial equity, and realizing that like as a major employer, the health system itself does have power to change the lives of the people around them. So that's another example of where we don't need to wait for Washington. We can just create better jobs ourselves in the moment. And then I think the other piece is that, again, to kind of get back to my theme of policies that exist or underutilized, is there are 2 policies that allow families to build assets, to build wealth without getting rid of all these cliff effect laws, which are challenging. And one of those is 529 college savings accounts that are available in a majority of states, and many states even incentivize opening them with a little bit of a cash benefit. For high income people, the benefit of opening these accounts is you get a tax break, but for low income people, the benefit is that it does not hurt your other public benefits. So you can still get your food stamps, you still get your housing subsidy, no matter how much you save. And there is some interesting research, mostly out of a randomized trial in Oklahoma, showing that the state put $1,000 into one of these accounts for young children, did nothing else. They've been following them for about 12 years, both that maternal depression rates decreased and that child development improved, even though families didn't have access to this cash. So again, kind of showing this idea that it is a health intervention. Nationally, only about 3% of families have these types of accounts, so it's hugely underutilized. So we've been doing work on getting people access to these accounts. And again, it highlights the disenfranchisement. Most people don't even know of Fidelity, the institution in Massachusetts that opens and holds these accounts. So there's just a lot of opportunity to do impactful work with a tool that's in front of us right now today. The other is a program called Family Self-Sufficiency out of HUD that allows people with federally subsidized housing to save and build assets as their income increases rather than paying increased rent. Very underutilized nationally, has enrollment rates of somewhere between 3 and 7%. We are working with one of our local housing authorities as well as another nonprofit to use the healthcare system to educate people about it, get them enrolled in this program. So that's another area in which, if you're wanting to do work locally, that you could start working with local collaborators and figure out ways to get people access to these programs.
I love the empowerment from our panelists of like Amy's giving out research topics, Lucy's giving out like people that you can like reach out to, like you are for our audience attending, like give us your questions, but we're also giving a lot back to you as to your next steps. So I wanted to posit a question of just kind of like the feasibility of putting all this together. Oftentimes when you give something, you take something away. And so when we think about wealth building policies, should broader wealth building policies like what we've been discussing replace or supplement more targeted programs? And how should policymakers be thinking about programs like the expanded child tax credit along other existing programs? For example, Mitt Romney had a proposal to expand the child tax credit, but it was in lieu of some of the other currently existing benefits. And so as we talk about like working across the aisle and finding balance and compromise, what are some of the panel's thoughts on how all those go together?
I'm happy to start. So this is not necessarily something that I claim full expertise in the economics of, so I will defer to others on that. But I do completely agree from a pragmatic standpoint, like there's a pot of money and we need to think about what will work and what's feasible. I think, when I hear proposals around replacement, it does make me concerned that we know the current resources are not enough to get families out of poverty. Getting food stamps and housing is not going to get your life on track economically. So it makes me a little concerned that we're just going to shift feel better about giving people cash, but it still won't be enough to really get them ahead, especially if we don't change the limitations on kind of how much money they can accumulate, or if we put a cap on their ability to get the cash. So I think that's one consideration and would require someone to run the numbers. I haven't necessarily seen compelling evidence or data, it's probably out there, but on, how much right now does it cost to administer SNAP and WIC and TANF and all these other programs, and how much total money are people getting from it, and how does that compare to the cash, and what amount would you really need to then get ahead? And I would say it's more than what's being offered right now. So I think that's an important place to start in thinking about it. I will say, I think there is theoretically at least an argument that putting more money into cash and less money into these other specialized programs could be powerful and cost savings. I know, for instance, with food stamps, or SNAP, we did a survey in our clinic this summer, found about a third of people who could be enrolled are not. And it's because it's so administratively burdensome. There's so much work that has to go into applying, to reapplying, to certifying your household income. It's based on monthly income. And so there's this constant flux in and out of the program. And I'd imagine that's quite expensive to run. And so maybe it would be cheaper to just give people that cash and stop having all these administrative rules. But again, my stance would be that you want to make sure you're getting people probably more than what they're getting right now, because we know that what we're doing right now is not enough.
Yes, if I can add on to this, it's, the question is a complicated one, but, it's true, just as Lucy mentioned, two things. First is administrative costs. So some programs are really complicated. And to the extent that their role is mostly to support income, and we replace it with a simpler program, it saves money. So essentially, you could potentially have a little bit more by saving those administrative costs. So generally, simplification can save money, and therefore, it's an effective thing to do. But it's also true that we don't want to make it such that there's going to be like no gain. For people, obviously, if we just merely shift, there might be no gain, but even then, there's going to be potential redistribution between categories. And even if that happens, we'll have to think about who, and somebody asked about the neediest, it might be the case that some people who are currently really needed don't have access. Maybe they nominally have access to something, but don't avail themselves precisely because of all the administrative difficulties. So for example, even without giving people more, but kind of reshifting the pot of money so that it's easier to access and people who are in most need are able to access it, might still be, a good thing to do. Now, of course, we actually also want to give people more, but, I think it can be, a little bit inflexible to think that we don't want to change anything at all. We're going to dig our heels in the sand for any change whatsoever, that could come as part of kind of reforming benefits. It's just that you have to think carefully about the effects. If we do this, then, what are the effects? And, how are we going to account for some of the potentially, negative effects that this could have?
So go ahead, Amy. Go ahead.
Oh yeah. The sort of just echo the same thing that both the other panelists have said, and we'll just add that when we think about like what the role of means tested programs are, right? So those means tests, they represent thresholds, right, and policy levers, but they are also operationalizing social constructions about who we deem to be deserving and undeserving. So part of the reason that these programs are so expensive and burdensome to administer is because we say, if you're experiencing the losing end of capitalism, we don't trust you. Right. And so we want to come out and police what it is that you're doing. Right. The idea behind unconditional cash is the exact opposite, which is saying like people know best what their needs are. And so just to kind of put that out there, that it's some of this administrative inefficiency, and there's a lot of it within social welfare, is there because we have these ideas about people who are struggling to make ends meet that are frankly inaccurate. And there's been an awful lot of science to demonstrate that it's inaccurate, and an awful lot of historical work done to show that they've been created that way to disincentivize people from accessing benefits that they're qualified for. That shame and blame piece really pushes people away. And so, on the one hand, I really think there is, and I know from the data, there's a lot of places to boost efficiency in the system and even shrink some of those social welfare programs down in lieu of some other things that are more flexible like cash. But at the same time, the work that we're doing, and of course we're doing it in an applied way, so we're looking at it a little bit differently. We don't advocate for eliminating the safety net because, I mean, frankly, the math doesn't even work, right? So cash is not a silver bullet. It is not going to eliminate all of our social problems. The cost of housing is one of the key drivers of poverty in the United States. And if we think about things like eliminating Section 8 or eliminating housing supports, right? Cash is not going to resolve that problem. So again, it's like to piggyback on what Dr. Marinescu is saying is that we have to think carefully about cause and effect, and how, it sounds really nice. I often have students come to me and they're like, hey, I read this thing and I just think it would be amazing if we just axed out the whole welfare system and we just gave everybody cash and look how simple and efficient it would be. And it's like, well, it's a little bit more complicated than that. And one of the things we've learned in Stockton and then with the other 27 RCTs that we have currently launching at Penn around cash is that you need to retain a bit of that human component in your design to get people to engage with program and policy uptake. So keeping in mind that end user and knowing that you've got to keep humanity involved in that process is something else that can build that efficiency in.
Excellent points all. And maybe one related question before we start to wrap up. The hour is like really flown by. But on a related question, sometimes this is from the audience. Sometimes you don't have to like reinvent the wheel. And so somebody asks like, what is the evidence in other countries that have nationalized health systems as well as universal basic income programs? How do these systems or programs work together to impact overall health and life expectancy? And so are there models elsewhere that we should be looking to of how to do this right?
Right. So, as I was mentioning, many European countries, in fact, all of them have a system of health, all Western European countries have a system of health that is universal. So everybody can get covered. So, this is very strange situation we have in the US compared to that model. Not only that, but they also have much more generous cash benefits across the board, but they're not necessarily, I want to say, universal basic income in the sense that, it's this really simple system where everybody gets the same amount. Of course, the rich pay more in taxes, but, it's a little bit there too, just like we have here, there's a bit of a piecemeal aspect. There's a bit of program for this and a program for that. But one thing they do have, by the way, most of them, again, is this child allowance. So, in the US, before this latest installment of the Biden plan, people with really low income wouldn't be able to access the child tax credit because it's a tax credit. So that if you don't have tax liability, so if you don't make enough to pay taxes, then you wouldn't get it. Whereas most other countries, including Canada, by the way, just up north, have a child allowance that is given to everybody. And so, I think we can learn a lot from that about the kinds of systems that are possible to have. And the other countries already do. So again, including universal health benefits and a child allowance. For example, the combination of those two, I see as pretty critical in protecting against poverty and especially child poverty, and thereby improving health. And also another thing I want to add to kind of the panoply of benefits is that you have to also think about the whole system in the sense that something like a flat benefit, it provides a floor, but if you're a family that's near poor but not quite among the poorest, what social insurance does is to provide you against from protection against income shocks. So for example, unemployment insurance, when you lose your job, it replaces your wage as a percent of your earnings. So that if you're making a little bit more, than absolute poverty wages, you're able to get a part of that while you're unemployed. And that's the critical insurance aspect of these systems. Similarly with health insurance, if you have, of course, this might not be necessarily a fully nationalized system, but here a health shock can be an incredibly severe income shock at the same time because of the cost. And so having health insurance, the whole goal is to be able to pay for that. So that we can continue to have a similar level of income, no matter the shocks that arrive in our life. That's the whole goal of the insurance side of the system, where again, the goal is to make sure that people are able to have over time similar levels of income, if not exactly the same, even when external shocks would normally lead them to have far less income. The insurance cushions them and allows them to go on. And that's very important. And this insurance aspect cannot be replaced by something like a universal basic income, because it's a flat that is going to be relatively low. So again, if you're just a little bit more than extremely poor, that's not going to necessarily be able to catch you. If you have a mortgage to pay, if you have, some expenses that, you would normally be able to pay with your job, and let's say you lose your job, that's not going to be enough then the universal basic income to cover your expenses. So there's, that's why those insurance programs cannot be meaningfully replaced, by the way, with something like a UBI, again, because of this feature that they just help people maintain a level of income that is similar to what they normally would have.
I am very sad to see that we are approaching 1 o'clock. I could talk to this esteemed panel for hours. As we wrap up, I want to posit one wrap-up question, and we're going to just go around and get thoughts from each of the panelists. What's one thing that you would like to be able to say about poverty in the US 10 years from now? And what's the most important thing that we need to do as a country to get there, or not do to be able to get there? Amy, we can start with Amy.
That's such a big question. Oh my goodness. And I only get like one thing. Come on, George.
I'll give a little flexibility.
Yeah. No, so I'll say two things in closing. So one, we tend to think in the United States as though poverty is some sort of force of nature. Like this is just this thing that happens, and oh my goodness, it happened. We better have a policy. No, budgets are moral documents. Poverty is a policy choice, right? And so just framing, it does not have to be this way. Just because this is the situation that we're in and this is what we've inherited from those who came before us doesn't mean that that's the way we need to move forward, right? And so just putting that framing out there that poverty is not natural. Poverty is a policy choice, and poverty by definition is lack of resources, right? So these are decisions that we can make. If I were to offer like one practical thing that I'd like to see happen, in terms of cutting poverty, would be, the expansion and permanency of the child tax credit. We have never, in 60 years, we've been doing the war on poverty. We have never seen a drop in poverty to the extent that we have with the expansion of the child tax credit. It's extraordinary. I don't think we celebrate it enough. So if there's one thing I would like to see happen, it would be permanency around that credit and a bit of an expansion.
Excellent. Thank you, Amy. Next, we're going to go to Lucy for your thoughts.
Great. Well, as a pediatrician, I have to say I agree with Amy that probably the most important thing we could do is make the expanded child tax credit permanent. To expand it, it should include more populations who are not currently included, including non-citizen children. I think in 10 years' time, as a country, we will be short-sighted if we did not invest in our children. I know it's really easy from a healthcare system perspective to overlook them. They're not very expensive, but the ramifications of growing up in poverty are devastating to physical health, to mental health, and to future productivity economically. So no matter where you are in the political spectrum, no matter what you think about poverty, you should have a self-interest in making sure that children in this country grow up with their basic needs met, so that, especially in a time of uncertainty with climate change and other stressors, we will actually have a functioning economy in 10 or 20 years. And there is clearly money in our country to make this happen. If you look at the wealth of billionaires that has been exploding during the pandemic, we are making policy choices to allow them to accumulate that wealth. And it doesn't have to be this way.
Thank you, Lucy. And Joanna, we'll end with you.
Great. So just like following up on those steps, I think there's great agreement in the panel. I would also say that continuing the expanding child tax credit, in the immediate future is one of the biggest steps that could be taken to improve the situation in the US. And it's a policy that has broad support among my economist colleagues. There's been a petition circulated among us to support that. And also there's a panel by the National Academy of Science that had looked into solutions to drastically cut child poverty. And this was one of them that was rated very favorably, based in particular on its advantages in other ways. Just as Lucy mentioned, it's important to see that giving cash to children not only helps them now, but it's an investment in the future of our society, which is good for them and also good for our society, as later on, they'll be the citizens of tomorrow and paying back in taxes and doing better for having received this cash during their childhood. So, I think this is really a critical area of policy that should be extended going forward.
Thank you so much to our amazing panel. You have provided us with so much to think about, so many amazing insights, and our audience has some good research questions to consider, some good petitions to go sign, and advocacy that they can do on their own. And so I just want to thank everybody for joining us. It has been a true honor to be with this brilliant group and to be able to moderate this panel. And I will turn it over to Rachel.
Great. I want to join George in thanking all of you for being on our panel today. It was really such a great conversation. And I love the framing that you gave of thinking about poverty as a policy, and as a policy that we can do something about. And so important to think about investing in our children today who are going to be tomorrow's citizens. So thank you for joining us. For those in the audience, also thank you for joining us. And I hope that you will join us for our next event, which is a conference. It's a 2.5-hour conference, which is going to be looking at, which is going to be about mental health care in the United States, and thinking about ways we can improve the way we deliver care. You can find more information about that on our website. It will be Friday, October 29th, starting at noon. So please join us then. And until then, everyone be well. Thank you.